So I'm very happy and pleased to be with you today. It's my first participation in the Arab International Pediatric Neonatal Medical Congress. I want to thank Dr. Sridhar for inviting me and all the operation team. So my topic is the approach to management of PPHN, persistent pulmonary hypertension of newborns. And it's very difficult, to be honest, to summarize in 30 minutes, but I did my best. It deserves like 2 days conference. I hope it will be short and clear. I have nothing to disclose. So the definition of the persistent pulmonary hypertension of the newborn is a syndrome where actually we have failure in the normal circulatory transition that should occur after birth. It might be due to delay or impairment in the normal fall in pulmonary resistance. So as you know, in fetal circulation, we have the placenta, who have the role of oxygenation, and then the blood will go through the umbilical vein to the right side of the heart. It will be mixed and it will go to the left side of the heart through the foramen ovale or the ductus arteriosus, the PDA. This is what is happening in the normal life. After birth, we will have the cord clamping, the placental circulation will stop, and we will have an immediate fall in the prostaglandin circulating level. The baby will cry and we will have the first few breaths, and we will have immediately, let's say, 5 to 10-fold decrease in the pulmonary vascular resistance. This is what should happen in the normal start of life. Once the PVR will reduce, we will have increase in the pulmonary blood flow. We will have a reversal of the PPHN from right to left, so from left to right. This will help in raising the PaO2 and will help in the PDA constriction. The increase in the pulmonary blood flow will also lead to increase in the left atrium filling and pressure, which will close the PFO or at least reverse the shunt again from right to left to the left to right shunt, and will lead to a normal neonatal circulation. In the PPHN, things are not happening this way. So we are having increased pulmonary vascular resistance and pulmonary vasoconstriction. We can have multiple factors that could happen even before antenatally, perinatal or intrauterine causes like congenital diaphragmatic hernia, sepsis, chorioamnionitis, or neonatal causes such as congenital pneumonia, RDS, or sepsis. This will lead to decreased pulmonary blood flow and hypoxia, which will increase the acidosis that may be already there, but it will be worsening. It will increase even more the pulmonary vascular resistance and increase the right to left shunting again, which will decrease the pulmonary blood flow. The incidence of PPHN is not like well known, but this is the statistics from USA. We have incidence between 0.4 to 7 for each 1,000 live births. And people were thinking before it was like only for term baby or near-term baby, but actually it's also affecting as much the preterm babies, around 5 per 1,000 live births. Since we had the INO and the ECMO, it really helped to reduce the morbidity and the mortality, but mortality is still high. Actually, it's around 10% for moderate to severe cases. As well as morbidity, so even the survivors are having like high morbidity, around 25%, even for moderate cases, not only for severe cases with neurodevelopmental delay or hearing difficulties. It's very difficult to find a clear classification for pulmonary hypertension. This one is including adult and pediatric. So as you can see, the PPHN is only one small subcategory of the group 1, and it is very complicated. The Panama 2011, they tried to separate the pediatric pulmonary hypertension from the newborn one, but the same is still very complicated for neonatologists. So the best classification to be used is the etiology one. So we will have, let's say, 7 big groups according to the cause. Sometimes we don't have a clear cause, so this is what we call the idiopathic. That means we don't have a clear lung disease, but the pulmonary perfusion is decreased due to the abnormal vascular remodeling, which will lead to pulmonary vasoconstriction. The second cause could be abnormal transition at birth, like RDS, TTN, or perinatal asphyxia, which will lead to impaired pulmonary vasodilatation at birth. Third cause could be parenchymal disorder, which we call the secondary PPHN, like meconium aspiration or pneumonia. Then we have the abnormal lung development, like the hypoplastic lungs, especially if we have oligohydramnios antenatally and renal dysfunction. If we have a prolonged rupture of the membrane premature and congenital diaphragmatic hernia or other malformation, pulmonary malformation. Then we can have the intravascular obstruction with hyperviscosity or polycythemia. That's why we have to do a CBC, and we can see this for the trisomic babies, for example. Sixth one is the pulmonary hypertension in preterm infant, especially in the initial phase of the RDS. And last one is the pulmonary venous hypertension, which are actually all the causes or anomalies in the left side of the heart. Pulmonary vein stenosis, mitral stenosis, left ventricular dysfunction, or a hypoplastic left heart. So for the doctors who are not familiar, maybe with, who are not always in NICU, when are we suspecting this PPHN? It will start with a newborn who is having profound or labile hypoxemia. Of course, we will go back to the history. Is there any meconium aspiration? If it's a term baby or no, cesarean section delivery or vaginal, if there was any history of oligohydramnios or choreo or trisomy. Then we will check the pre and post-tactile saturation, and we will find a gradient difference equal or more than 10%. But as you can see, there is nothing specific about the PPHN. So we will need a cardiac echography, and it's playing a major role in this pathology. First of all, to rule out if there is any congenital heart disease. And second, we will see to assess the severity and the myocardial function. We can have a baby with respiratory distress symptoms, non-specific as well. The auscultation will find a single second heart sound with harsh murmur that is due to the tricuspid regurgitation. And in severe cases, baby can have hypotension or even symptoms of shock. We will have to rule out many different differential diagnoses, starting by the congenital heart diseases like TGA, obstructed TAP PR, tricuspid atresia, or pulmonary atresia with intact ventricular septum, or the parenchymal lung disease. So of course, we will do an X-ray. In the PPHN, most of the time, the X-ray will be normal, or we will just see cardiomegaly and increased right side of the heart, the ventricle. But if there is any pneumonia or sequestration or hypoplasia, it will be evident on the X-ray. We have to rule out sepsis. We will keep in mind if it's not a surfactant protein B deficiency, if the baby is not responding to any treatment. We have to think about all the other reasons of acidosis, metabolic or respiratory causes. The meconium aspiration syndrome, in general, we have a history, evident history, as well as the asphyxia. So as I said earlier, the cardiac echography is really an important tool, and it's playing like major role to rule out the congenital heart disease, but also to characterize the severity of the pulmonary hypertension to assess the myocardial performance. That's why it's very important to improve our skills as neonatologists for the cardiac echo, or if we are not able to do it, we have to refer to pediatric cardiologists as soon as possible if the baby is not improving. The cardiac echo will help us to assess pH severity. The gold standard is normally the right heart catheterization, but of course we are not doing it in newborns, maybe for the pediatric population, but not in newborns. So the echo will help us to have indirect signs to evaluate the severity of this PPHN. Like the tricuspid regurgitation jet, the intraventricular septal morphology, if it's bulging from the right side to the left side, that means the pressures are higher on the right side and it's compressing the left heart. The shunt patterns, of course, the PDA and the PFO, if it is right to left shunt, and the pulmonary artery acceleration time, which should be reduced. Echo will help us in evaluating the myocardial performance, but because of the same reason that catheter is not doable in neonate, so we will be more able to follow actually and to monitor the treatment response. And we will use it in combination with the clinical progress, as well as the calculation of the oxygen index, and not only the cardiac echo, because you have to be aware of the limitation and challenges of this echo, and it must always be interpreted in clinical context. Regarding the management, in 2015, the American Heart Association and the American Thoracic Society published the recommendations and guidelines for the management of pulmonary hypertension in pediatric population. And these are we have 8 important points with the high level of evidence. So the first one is that the nitric is indicated to reduce the need for ECMO in term and near-term infant with PPHN or hypoxic respiratory failure when the oxygenation index is superior to 25. This is class 1 level A evidence. Second, that is the lung recruitment strategies can improve the efficacy of nitric therapy and should be performed in patients with PPHN associated with parenchymal lung disease. And this is also class 1 level B. Third one is that the ECMO support is indicated for term and near-term neonates with severe pulmonary hypertension or hypoxemia, refractory to the nitric and all the optimized ventilation and cardiac function. Level 1, class 1 level A. Fourth point is that the evaluation for disorders of lung development, such as alveolar capillary dysplasia or rare disease like genetic surfactant protein disease, is reasonable if these infants are having severe PPHN, not improving after using all the possible management tools, vasodilator, lung recruitment, and ECMO. Then the sildenafil is a reasonable adjunctive therapy for infants with PPHN when they are refractory to the nitric, especially if the oxygen index is superior to 25. This is class 2A level B. And the inhaled prostaglandin analogs may be considered as adjunctive therapy as well for infants with PPHN who are refractory to the nitric and are having also oxygen index superior to 25. The IV milrinone is reasonable for infants with PPHN when they are having signs of left ventricular dysfunction. And finally, the INO can be beneficial for preterm infant as well, especially if they are having severe hypoxemia and when it is due primarily to PPHN physiology rather than parenchymal lung disease, and especially when it is associated with a history of PROM. So if we go back to the treatment tools, the most important one will be the ventilation strategy. You have to try to recruit your lungs. If your lungs are closed because of atelectasis, lung collapse, or surfactant deficiency, or whatever, even if you start nitric, it will not work. So first of all, you have to assess the severity of this hypoxic respiratory failure. And that's why we'll start by calculating the oxygenation index, which is the FiO2 percentage multiplied by the mean airway pressure multiplied by 100 and divided by the PaO2. The severity is classified to to mild if it's 15, moderate between 15 to 25, severe between 25 to 40, and very severe if it's more than 40. So how we will be optimizing the ventilation by recruiting the lungs? Actually, we have to increase the PEEP, but at the same time try to be gentle for the inspiratory pressure. The aim is to achieve a lung expansion with a good FRC, functional residual capacity. And on the chest X-ray, anterior posterior chest X-ray, you have to calculate around 8 ribs expansion. We have to avoid underinflation as well as overinflation because both of them will increase the pulmonary vascular disease. Underinflation can give lung collapse, atelectasis, which will increase the intrapulmonary shunt, leading to more hypoxia and more hypercarbia. And overinflation will decrease the venous return, which will increase the hypotension, and baby will deteriorate more, and you will not be able to start IV medicine. Regarding the ventilation mode, there is a big debate, but we can use both of them, conventional or high frequency, to reduce the ventilation perfusion mismatch. Many studies try to compare the effectiveness of both strategies, but actually there was no difference in preventing the ECMO. But if we combine the high frequency with the nitric, we are having much greatest improvement in oxygenation, especially if the baby, the newborn, is having diffuse parenchymal lung disease or underinflation. And same for the infants, if they are having RDS or meconium aspiration syndrome, they will also benefit more from the combination of high frequency and nitric oxide. And again, the gentle ventilation strategy with optimal PEEP and relatively low PIP to allow some permissive hypercapnia are now being recommended to avoid excessive lung expansion or barotrauma. Coming to oxygenation, of course, the first reflex when baby will start to desat, that will increase FiO2 more and more and more. But actually, even if there is no clear target range for the patient with PPHN for the ideal oxygen saturation, we know that hyperoxia, like PaO2 more than 100, will not enhance the pulmonary vasodilation. But it will have consequence like increasing the oxidative stress. So in general, most of the NICUs or teams, they are targeting the lower limit of pre-ductal saturation of 92, which will provide a buffer to hypoxic pulmonary vasoconstriction. And then we'll fix an upper limit to 97, which will ensure optimal balance of pulmonary vasodilation with, at the same time, minimizing the adverse effect of from oxidative stress. Oxidative stress will give lung damage, so we have to avoid. Other treatment that might be useful depending on the etiology is the surfactant. But actually, surfactant was proven to decrease the use of ECMO only in some causes like RDS, meconium aspiration, and sepsis, but it was not proven in idiopathic PPHN. Combined with the high frequency, we are also reaching much better results as we are able to recruit the lungs. Then I kept it at the end because I want to insist on the ventilation management, but of course we will have to use a vasodilator such as nitric, which is the most important one and is selective vasodilator. And sometimes, if it's not enough, we will have to use non-selective vasodilator with IV, oral or IV medicine, such as sildenafil, Flolan, which is epoprostenol sodium, or bosentan, if it is available. INO was really the game changer for the PPHN. Combined with the high frequency, it resulted in less ECMO use compared to either alone. INO appears to be well tolerated despite theoretical risk, like some studies, and some doctors are still convinced that it might give brain intracerebral hemorrhage, IVH. But it was not clearly actually proven. But of course, we have to continue to monitor very closely the methemoglobin level and the NO2 level. We didn't find any increase in number or type of adverse events reported, and no apparent long-term difference in neurodevelopmental outcome. But there was no apparent difference in mortality. There is a recent question mark about the cancer. One study was published with the conclusion that nitric might increase the risk of cancer by 0.1%. But actually, for preterm baby and even term baby, they are exposed to so many other risk factors that we cannot conclude. But I'm just mentioning it here if the parents might ask you about this. So as a conclusion, as part of an overall global management strategy with the cardiac management, hypertension management, good lung recruitment, INO is an effective adjunctive therapy in term and near-term newborn. But what about the preterm babies now? Long time ago, many NICUs, doctors, neonatologists were not like in favor of using the nitric in preterm infants, especially for this risk of increased risk of IVH. But recently, I didn't find local statistic, but this is from UK. We can see a big increase of the use of the nitric in preterm babies. So in the last 10 years, it's like triple or 4 times more than in 2010. And a very good study showed that especially if the baby is preterm with oligohydramnios history and hypoplastic lung, we are really able to have a very good result after starting the nitric oxide for preterm babies. It will improve oxygenation in 95% of cases and improve the survival rate for these preterm babies. So quick summary for the management. I didn't talk about the supportive therapy, but it is very important. As you know, a baby who's having PPHN should have a minimal stimulation. We close the eyes, put earmuffs, avoid to change the position too often, avoid to suction too often. We have to maintain normothermia, normoglycemia. All electrolytes should be normal as well, especially if we start other medicines. Sometimes we need sedation and analgesia. So all this is like a very important and necessary part of the management of these newborns. Then again, the lung recruitment with the good PEEP. The oxygenation, we already talked about it with a target between 92 to 97. The surfactant in some cases, especially if there is parenchymal lung disease. The vasodilator, and then the inotropes and vasopressor. And if we tried everything and it's not working and it's term baby or near-term baby, we have to think about the ECMO if it's available. This is a very nice strategy of management for those baby, according to the result of the echocardiography, the blood pressure, and the evaluation of the cardiac function, in which case we have to use which inotrope or which medicine. So of course, first of all, the lung recruitment again, and if needed, the surfactant. Then if we have a normal blood pressure and a good cardiac function, we will give oxygen to avoid hypoxia. We will try all the time to have a normal pH and the normal PCO2, and we will start the nitric if the oxygen index is more than 15 to 20. If the nitric is not available, we can start inhaled prostaglandin or sildenafil, IV or oral, whatever is available in your unit. Second one is the normal blood pressure with cardiac dysfunction. It's better to start the milirenol IV after, of course, close monitoring of the blood pressure. As you know, you might have hypotension as a side effect. If we have low blood pressure and good cardiac function, we can give bolus, first of all, 10 ml per kg. And then we can repeat it once more if needed. If it's still not working, we can give a trial of dopamine. Then we will try norepinephrine or vasopressin. And then we will come to the oxygen. And of course, all the time, try to have a normal pH and PCO2, start nitric and hydrocortisone. And last one, if you have low blood pressure and cardiac dysfunction, with a rapid deterioration, you have to think quickly about the ECMO, if it's a term or near-term baby. Meanwhile, when you are waiting for the ECMO, you can start the bolus and milrinone, and according to the echo, start dopamine, epinephrine, and hydrocortisone. If all of this failed, again, you have to think about the ECMO if it is available. The ECMO is less indicated nowadays since we are having all the other adjuvant treatment. And fortunately, it's not accessible in all centers or countries, and is still having a high rate of mortality and morbidity. The future, there are so many studies for the antioxidant, the L-citrulline, the soluble SGC activators, but we are waiting for further studies and better evidence. Final word for the outcome, as I said earlier, even if it's a moderate
Dr. Olga, you have a few minutes. Yeah?
Okay, yeah. Even if we have, moderate PPHN, those kids can have severe neurodevelopmental outcome. So surviving infants, they will often require prolonged cardiorespiratory support. They will stay longer in the hospital. So for sure, they are at higher risk for long-term adverse outcomes. For near-term PPHN infant, recent evaluation showed around 10% of mortality, 5% of cerebral palsy, and 45% neurodevelopmental delay, which is very high for near-term infants. For the preterm PPHN infant, we have limited data, but the mortality is very high, around 50%. And the survivors will have cerebral palsy 3% around, and neurodevelopmental delay due, of course, at the same time to the prematurity and to the disease itself. We don't have evidence of impact of nitric on long-term outcomes in babies with hypoxemic respiratory failure. So I think even when you tried everything, let's say for a preterm baby, and you don't have any choice, personally, I will give it a trial if it's available in the unit. If baby is responding, I will continue. If baby is not responding, I will try to stop it quickly. So as a conclusion, the PPHN management could be very challenging sometimes. It requires very good clinical skills, good cardiac echo skills, and accessibility to nitric on other medicines. If you don't have this cardiac echo skills, please refer to a pediatric cardiologist, because let's take an example of a preterm baby who was having a PDA. We tried to close the PDA with ibuprofen, and suddenly he started to deteriorate. So you cannot just conclude that it is a PPHN. You will need a very good cardiac echo, of course, to conclude and show that there is no other congenital heart disease. But maybe this baby was not ready for the PDA closure, and we will have to try to open it again. So this is one example. We cannot just try and suggest. Cardiac echo is a mandatory part of the management. And of course, I will insist again for the importance of the long-term follow-up for all patients, even the mild cases, not only the severe ones. Thank you very much.